All right. Hi, everybody. Thanks for joining us. We are in live session number 7, Care Coordination, a model for empowering caregivers to support children with medical complexities. Thanks for joining us at our RCPA conference this year, Vision 2020. I'm Cindy Havitz, one of the policy directors at RCPA, and it's my pleasure to be here today. Before we get started, a couple of things. I just want to let you all know that you are muted. We will be using the question and answer box for questions through this presentation. And there is a chat box, but I will not be monitoring that during the presentation. So if you have questions, please go ahead and write them in the Q and answer box. Dr. McTighe here is willing to accept questions all throughout the presentation. So if something doesn't make sense or you want follow-up, go ahead and write it in at any time. Following her presentation, we will have a formal Q&A session as well, but you can feel free to type them in at any time. All right, so it is my pleasure to introduce to you today Dr. Amy McTighe. She is the Director of Care Coordination at the Children's Institute in Pittsburgh, Pennsylvania, and she has been graciously willing to share her expertise with us today. So Dr. McTighe, I'm going to pass it to you to share your screen and the presentation, and we look forward to what you have to share.
Okay, great. So let's see here. Oops. Okay, can you see the screen, or just wanted to make sure? Can you guys?
Yes, we can see it.
You can? Okay, great. So let me see if I can do the slideshow part. And how about now? You can still see it?
Yep, it looks great.
Okay, great. So as Cindy mentioned during the introduction, my name is Dr. Amy McTighe. I am the Director of Care Coordination here at the Children's Institute of Pittsburgh. I apologize in advance if there's some barking during the presentation. I have a 7-month-old puppy, and she really doesn't know Zoom etiquette yet, but I have her in the other room, so hopefully you won't hear her as much. So I wanted to just give you a little bit of background about the Children's Institute first. The Children's Institute is an organization that was established in 1902. And it's an independent nonprofit licensed organization that's dedicated to improving really the quality of life for children, young people, and their families. And we really provide specialized continuum of services that enable children to really reach their full potential across the lifespan. And so our pediatric rehabilitation programs are also nationally recognized. We also currently have an outpatient behavioral health clinic. We have a day school program that serves over 200 students from about 65 different counties. And we also have family services that offer a variety of services such as adoption, foster care, and intensive family services. So in regards to care coordination that I'm going to talk about today, we offer 3 very distinct programs. Our first program is infant care coordination, and that program actually supports women prenatally and also infants and children up to the age of 3. Those clients that are enrolled in that program are actually exposed to substances prior to birth, such as drugs or alcohol. And then we also have a care coordination program that supports individuals 14 and above who have a current or past history of substance use. The individuals that are actively seeking treatment or drug and alcohol treatment, or are enrolled in drug and alcohol treatment programs, and those also individuals that have recently relapsed from with drugs and alcohol. The program that I'm going to talk about today is we have care coordination services that support children with medical complexities ages birth to 21. And these services also support children with behavioral health care needs and typically developing children. But I'm going to talk a little bit more about that later in the presentation. So today we're going to discuss how the care coordination program is delivered And so during this webinar, we're really going to examine the current model of care coordination that we have being implemented for the pediatric population here at the Children's Institute. And then we're also going to analyze the efficacy of the care coordination model for this pediatric population and for those medical complexity kids. And then we're going to generalize how the care coordination services can be applied to many different pediatric populations, specifically for kids with medical complexities. So first, I think it's important to talk about what care coordination is. And so care coordination actually means a lot of different things to different people. And interestingly enough, there's really no consensus on what that definition is and how it's and what it's actually about, and because it's really defined by what the agency defines it, or the perspective that you have as the person delivering the care. But the definition has really fully evolved. And so there was a recent systematic review that identified over 40 different definitions of the term care coordination. And so the authors of that specific study that are noted at the bottom of this slide, they actually combined all of those common elements from those definitions and decided that they were going to develop a really broad definition of care coordination, which is actually here on the screen. And so care coordination, the way they defined it, is that deliberate organization of patient care activities between two or more participants, including the patient, so making sure that the patient is really heavily involved in their care as much as possible, and that involved in a patient's care to facilitate the appropriate delivery of healthcare services. And what that definition also includes is organizing care that involves the marshaling of personnel and other resources needed to carry out all required patient care activities, and is often managed by the exchange of information among participants responsible for different aspects of care. So for some purposes, these authors, the authors that are noted on this slide actually noted other definitions that may be more appropriate, that are more specific to specific agencies. But the lack of consensus is perhaps not really surprising that much, given that the many different participants that are involved in coordinating care is so present. So we're going to talk a little bit about the successes and failures in care coordination. Really will be perceived and really are measured in the different ways depending on the perspective of the person that's involved. So there's the parent in the family that has one perspective, and then there's the healthcare professional that has one perspective. There's that system representatives that has another perspective, and then there's a lot of other people that are involved along the way. So the consideration of those views from these three potentially different perspectives is really important when you're measuring care coordination comprehensively across the board. And so from the parent, so if we think about the patient and client and family perspective, what this study saw was that this group of consumers were interested in defining care coordination as any activity that helped ensure that the patient's needs and the preferences for health services and information was shared across people and functions and in locations and sites are met over time. So the patients and their families actually really, in other informal caregivers, really were experiencing failures in care coordination, particularly at points of transition. So what was happening is that transitions in between specific care settings, or transitions between from an inpatient hospital program to participating in the community, and those types of things. So the transitions that occur between those healthcare entities and over time are typically characterized by shifts in responsibility in that information flow. So what happens is whenever they go from one service to another, families in this specific study reported that they were at times reviewing the exact same information with all of the care providers. And they really perceived failures in terms of unreasonable levels of effort that were required on the part of themselves or their informal caregivers to meet the care needs during those transition times among healthcare entities. So that was the family's perspective. In this specific study, when it discussed the definition of care coordination, the other perspective that they looked at was the healthcare professionals. And that care coordination, what their perspective on care coordination was that it was a patient and family-centered, team-based activity, really designed to assess and meet the needs of the patient while really helping them navigate effectively and efficiently through the healthcare system. And so the clinical coordination involved really determining where to send the patient next, and that's sequencing among specialists and what information the patient needed that was necessary to transfer from among healthcare entities, and how accountability and responsibility was managed among all healthcare professionals, the doctors, the nurses, the social workers, the care managers, the support staff, anybody that was the in-home nursing agencies. And so the care coordination in the healthcare professional perspective was really addressing potential gaps in meeting the patient's medical, social, psychosocial, and medical needs across the continuum. And so the healthcare professionals noticed failures in care coordination, specifically when the patient or the client was directed to the wrong place, or they were getting the wrong type of service. And then what they were seeing was happening was that that there was a lot more child welfare calls because those medical needs were not being met. And then the systems perspective is really where care coordination was looked at as the responsibility of any system of care to integrate personnel and information and resources all across the board and make it make that continuum of care and that care coordination program really decrease healthcare costs so that they don't need to access very expensive healthcare settings in specific situations. So for example, for the kids with medical complexities that we're going to talk about today, by providing care coordination, the system representative perspectives was looking at, really decreasing healthcare costs and things like emergency room visits or call-offs and with nursing agencies, and what do parents do when they have a call-off for a nursing agency or something along those lines. So really all of the perspectives really brought in a definition that anything that bridges the gaps along the care pathway was something that was really important. And then the successes and failures in care coordination are really perceived depending on that perspective. And so that is actually what we modeled, those perspectives is what we really modeled the care coordination program on at the Children's Institute that I'm going to talk further about now. So care coordination at the Children's Institute is a model that we've implemented. It's this model is considered to be prevention and diversion program. And when you think about those words, prevention and diversion, we really think about, well, what does that mean? And so this can mean a variety of different things. And so it can mean that when the service is provided to children with medical complexities and their caregivers, that or infants born drug or alcohol exposed, or whatever subsection of the population you're thinking about, it really can mean that you're trying to prevent them from you're trying to prevent them from provide them with appropriate resources so that it reduces those medical risks and threats to overall health. So what I was talking about previously, that we're trying to make sure that they have all of the necessary things in place so that visits to the emergency room don't have to occur frequently. So we're really preventing and reducing medical risks and threats to that overall health piece as much as possible. We also see prevention and diversion in this program defined in a way that relates to safety. And so, for example, by providing this service, we really look at, and we have some numbers that show this that I'll share at the end of the presentation, that really we talk about prevention and diversion by diverting a family from being identified under the child welfare system because they're unable to meet those medical and psychosocial needs of the child, because they're overwhelmed with everything that is going on, and overwhelmed with everything that caring for a child with medical complexities entails. So we really look at that prevention and diversion piece as being one where they're not being referred to child welfare because this service is being provided. So this care coordination program also focuses on a really holistic approach to care that is heavily routed in the concept of focusing on that family and that caregiver empowerment. So the ultimate goal in our program is that the caregiver obtains the correct skills and the necessary resources that they need to provide that quality of care to their child with medical complexities. So the job of the care support coordinator that works with the families directly is really to provide those resources and those empowerment skills for the families to be successful. In order to provide that quality of care, the goal is to introduce the caregiver to community resources and that are gonna, and supports that meet the individual needs that have been identified in the care plan at the time of intake. And so the care plan at the time of enrollment services, basically, there's a lot of information that is gathered that identifies barriers in 11 different domains. And the ultimate goal of the care coordination plan and the support from the care support coordinator is to meet the family where they are, to provide that support for overall health and wellness and decrease those barriers that they've identified in those 11 different domains. So when I talk about the 11 different domains of care and support, this slide shows exactly what those domains are. And so when we address information and gathering of information session with the client during that intake assessment, the care support coordinator gathers information from the client on all of, excuse me, hold on one second. So it gathers information from the client in all of these 11 different domains. And so these domains, when you look at these domains, you think of you look at healthcare coverage. You look at, does the client have healthcare coverage? Is there a need for food resources and food security or transportation under basic needs? What is their physical health diagnosis? Do they have any emotional and mental health concerns or diagnoses in relation to that piece of the domain? What is their current family structure? Are there housing concerns? What is their current childcare situation? If they have a in-home nursing for their child, what do they do when that nursing agency calls off or they don't have that available support? Are there specific educational needs on the part of the family? Are there language barriers? Is there any legal status activity? So are there anything that the parent has unresolved legal action again that they need to deal with legal support? And then social and life skills. One of the things that we see a lot with the barriers for people in these domains is that social piece, is that it's really difficult to bring their kids with medical complexities out into the community. So what are some places and activities and supports that they can do to make them more comfortable, and how to support that specific, need? The model, like I said, that I'm going to describe is really can support children with medical complexities. And then the other populations that we serve is also supports children, infants that are born exposed to substances, children with a behavioral health diagnosis, and we also support individuals 14 and above with a history of drug or alcohol use disorder or behavioral health needs. We also see in this same model children that are typically developing that can also be referred to the program for concerns such as missed medical appointments, missed well child visits, things like that, school truancy, dental needs, safety issues, things like that. There doesn't have to be, in this specific model, most of the referrals that we get, there does not have to be an open case with CYF in that county, but we can have clients that have an active case in CYF, and they can also be clients that are soon to be closed with CYF, or a completely closed case. So I'm going to talk a little bit more about where we get those referrals. So typically, I specifically used Allegheny County, where we have one of our current contracts in. So this slide shows some of the locations where we have received referrals from Allegheny County. Referrals can be received from children, youth, and families through the Department of Human Services. We can also receive referrals from the Bureau of Drug and Alcohol or the Office of Behavioral Health. The referrals can also be received from pediatric medical offices in Allegheny County, or outpatient pediatric therapy agencies like the Children's Institute, Family Links, any of those places, as long as they live in Allegheny County. Many of the kids that we serve in this program for children with medical complexities are referred from the Complex Care Clinic at the Children's Hospital of Pittsburgh, UPMC. Clients can also make a self referral, and we will have some clients that make a self referral in that drug and alcohol program. The only requirement for services is that the client lives in one of the counties that we currently are contracting with, and that the client shows a barrier in at least one of the 11 domains that I described prior. We currently, just for your information, we currently have contracts with Allegheny and Washington County. We're finalizing a contract with Butler County, and we are in initial discussions regarding contracts and finalizing those contracts with Beaver County and Greene County. But we're growing at a fast pace, so our ultimate goal is to get this service into as many counties as we possibly can. So once the referral is made, I'm going to walk through the process now of exactly what this looks like. So once the referral is made, the client is contacted by phone or virtually by FaceTime, Zoom, Microsoft Teams, whatever it is. They're contacted virtually by the care support coordinator. And the care support coordinator's job is to identify all of those barriers that the client and family has in those 11 different domains that we talked about. And then once they identify barriers, they create a care plan that includes measurable goals of what the family is going to accomplish during their enrollment in the program. And when I talk about measurable goals, you'll see that what those measurable goals look like when I go through a case study. And so the measurable goals are really very clear cut and focused on, from start of enrollment to the time of discharge, I'm going to accomplish this. And this is the toolbox that I'm going to have for moving forward after I'm discharged from this service. The other job responsibilities of the care support coordinators are to collaborate with all of the healthcare providers. So when the parents talk, or the caregivers talk about the specific specialists and doctors and PCPs and all that stuff that these kids go to, that is, make sure the job of the care coordinator is to collaborate with those specific medical professionals to make sure that the appropriate care that they're reporting is happening is actually happening. So they really coordinate those community services, and they optimize those healthcare outcomes in order for there to be, like, parents making sure that they're attending those appointments and that they're not, no showing for appointments. The care support coordinator also works really collaboratively with the family to ensure that the goals that have been identified in the care plan are being accomplished. And so, but most importantly, this program is really focusing on teaching and empowering the parent with skills and a toolbox with all those necessary skills to provide that quality of care for their child, so that, like I said before, there is that decrease in healthcare costs across the continuum. So additionally, the care support coordinator may coordinate well visit appointments with the child's pediatrician or the specialists, and ensure that those appointments happen timely and in the right order. So by having the appointments happening timely and in the right order, again, that is a thing that decreases healthcare costs. That the perspective of that service, those service representatives are really significantly decreased. So for example, we had a client that her child had an earache, and the mother wanted to schedule immediately wanted to schedule an audiology appointment to obtain a hearing test because she felt that the child may have a hearing impairment. The care support coordinator really worked with the mom to see what were some of the signs and what the mom was observing in that specific situation, and made an appointment with the child's PCP. What was determined in that appointment was that there was earwax buildup, which was the lower healthcare cost option. So when the family went to the PCP and that earwax was extracted, the earwax was extracted and the child was able to hear better. And so there really was no need to go through an audiological evaluation. And so the provider for that specific client was really pleased with that outcome, because we were able to show that it not only decreased healthcare costs, but met the parent and the needs of the child in that medical way. Identifying community resources is also something that's a really important part of the service delivery for the family, for the care coordinator. So resources provided may be identifying specific diaper banks in the area, those food banks, free clothing, public transportation or transportation options. The other thing that's really important is that we identify supports in the community that make sure that those resources are really provided and easily accessible for the client. So for example, if the client or the family or the caregiver is in need of free diapers, we are going to provide a resource in their specific home community, not a diaper bank where the family has to drive 30 miles to obtain free diapers. Or we're going to provide a food bank or a food security resource in the community that is very close to their housing situation, rather than all the way on the other section of the city. So those are just some of the things that the care support coordinator looks at, but it doesn't mean that it's just limited to those items. So the other thing is that the care support coordinators look at working on coverage needed for services. So some of the families aren't aware of what coverage that is provided for their specific from their specific healthcare plan. They review progress with physicians and medical teams. So they may, there might be a specialist appointment with endocrinology, and the care support coordinator would remind the family of that appointment, and then make sure that they followed up with the healthcare provider and the endocrinologist to determine what the next steps or recommendations were, and then really break those recommendations down into the family understanding it at their level. We have a lot of families that are very not confident to ask questions to healthcare providers because they're just afraid of that they're going to look stupid, or they're not going to be able to ask appropriate questions, and they're unsure as to why a specific recommendation for medical needs was made. We really encourage the family to follow up with developmental pediatricians. We support all of that school piece where we're recommending early intervention services, and we're setting them up for those therapies to come into the home, or we're setting them up for home-based therapy through school, providing any behavioral health resources and along those lines. So it really is dependent on what those barriers are that are identified by the family in that care plan when they first are provided or enrolled. And so, so the first, as I've stated, each care plan is created based on the barriers identified in each of those 11 domains. And so I'm going to walk through a case study and how the care plan was created for this specific referral. This specific referral was a child with medical complexities due to her mother testing positive for substances at the time of delivery. So this actually goes into the, not only was the infant testing positive for substances, but she also had medical complexities because of that substance exposure. In this specific family, there were also two other siblings. Mom was a single parent. There were two other siblings, a 4-year-old girl, our daughter, with autism, and the mother also had a 2-year-old boy. And then he was typically developing. The barriers that mom identified during admission were the barriers that mom identified during admission there were some barriers in physical health. There were some barriers in another domain of emotional and behavioral health. She had some barriers with basic needs. There were some barriers with employment and the ability to be financially stable. She had some barriers in education, in childcare overall, and then there were some issues with legal concerns that she needed to take care of, and as she was moving forward and supporting her children. So the first part, so the care plan looks very similar to this, and so this is looking at what the goals are and what the care support coordinator is responsible for completing during enrollment. So in physical health, the caregiver was having difficulties with scheduling well visits and attending those visits on a consistent basis. And so the caregiver had missed, at the point of referral, had missed 100% all of the scheduled wellness appointments that were scheduled for the past 3 months for all 3 kids. And so a goal that was created in that care plan was, after providing education on the importance and process for scheduling medical well visits in a timely manner, the caregiver will schedule and attend all wellness visits with support from the care coordinator. So some of the activities that we did here with this family were set up a system where she was able to take her cell phone, put reminders in, alarms, add these appointments into her cell phone calendar. She was able to really organize herself and empower herself to be able to save appointments and save an alarm for that to occur. We also incorporated phone reminders, just like any other people, anybody else gets from those physicians. And we also incorporated like that organizational schedule where she felt more empowered of knowing and more comfortable of what was going on for each kid. When the other thing that she had difficulties with, this specific mother, was that she felt very, not confident with asking questions to the medical provider where she was going. So she would just say, no, I'm fine, I don't have any other questions. And then after the appointment, she would call the care support coordinator and really just completely break down and say, I didn't understand this, I didn't understand this, I didn't understand this. And so we provided her with some self-advocacy strategies. So the caregiver was going to ask questions related to that medical care of her child when attending 2 scheduled appointments in the month of October. So that was, those are some of the things that we're working on with her now. We're providing her those, self-advocacy skills, and that, something as simple as write your questions down on a Post-it or a piece of paper or whatever and bring them with you. We'll go over those before you go, and then really making sure that she feels comfortable to ask those questions. The care support coordinator actually then would follow up with the medical provider within 48 hours to make sure that questions were asked, that those were documented in the chart. Did the parent ask questions? And those answers are typically something that we are able to obtain from the nursing staff or that medical specialist professional. So the family also, in this specific situation, also identified transportation as being a problem. She recently moved to the city of Pittsburgh and was unsure how to ride the public transportation in the city. The mother's primary language in this specific case was Spanish, and she had difficulty with public transportation in Pittsburgh due to the language barriers. So after we did 4 in-person lessons, so we did like a virtual lesson on how to read a bus schedule, how to ride that public transportation. she was able to use that public transportation to arrive at Children's Hospital for a scheduled appointment. And what ended up happening was we did something as simple as mom understood what she needed to do. We met her at the bus stop. The care support coordinator met her at the bus stop of where she was supposed to get off, noticed that she got off, she went into the appointment, and we went from there. So it's, making sure that they have those skills necessary and empowering them to, take on transportation on their own. We didn't transport them, but we gave her the skills that she needed to be successful. In the area of education, as I talked about, this mother's primary language was Spanish, and she was really interested in taking some community free English course. And so we were assisting her with registering for a free English course that was being offered at the local public library. This class was actually was something that she did online, and so she just got like a free basic English, English interaction skills and things like that. She did it online instead of at the local public library, but and the goal, the measurable piece, is that she was going to complete that by the end of October. Her last class is actually next Friday, so she's been doing those once a week online, and so she'll be having that completed by the end of October. Is in regards to childcare, the parent reported that what was really difficult for her was that her current employment setting, she was missing about 50% of her work shifts because she didn't have childcare scheduled for her child for all three kids, but most importantly for her infant with those medical complexities. And so the care support coordinator assisted the parent with really creating a schedule for childcare. She didn't want to go to a brick and mortar childcare facility in the community. She really wanted to use natural supports that were provided in her social circle or her family circle. So she used the maternal grandmother, who was also, living in their area, her sister, and then a family friend. And we created a schedule to say, okay, this is your schedule for work. Who out of these natural resources and supports are able to watch your kids during the time that you need to go to work? And we really want to make sure that she's able to attend her work shift 5 out of 5 days per week. So again, you see that measurability of that care plan goal. For emotional and mental health, one of the goals that we included here was that mother was interested in obtaining a behavioral health evaluation that included substance use disorder treatment. The parent previously had not accessed any behavioral health resources and verbalized really the need for substance abuse treatment, and understood that in order for her kids to progress along the way medically and emotionally, she needed to be stable as a caregiver. So she felt that that the way to do that was to access substance abuse treatment. And so we were able to, and behavioral health resources, and we were able to provide her with resources in order to get her set up with those appointments. One of the things that was recommended for her daughter, the 4-year-old daughter, was applied behavioral analysis therapy. And the care support coordinator assisted the parent with scheduling that ABA therapy for the 4-year-old daughter. The parent did not have any idea what ABA was. The doctor that gave her that recommendation just said, oh, well, ABA therapy is recommended, and then left and went to the next patient. And she's like, I have no idea what that is. So a lot of the work here for the care support coordinator was really to explain what the importance was of that therapy and why that was going to help her daughter in so many different ways in so many different environments. They didn't understand. She didn't really understand autism in general. And so that was something also that the care support coordinator was able to give resources and support to say, hey, this is what autism is. Let me give you some resources. Let me show you some community agencies that would help you understand this diagnosis and get more information. So the case review, so once the care plan is created, we also have a case review system that is completed with clients on a regular basis based on their level of need. So when you look at when the clients are enrolled in the program and the care plan is created, what happens is that they're assigned a tier level. Tier 1 being the lowest level of need, Tier 4 being the highest. And what happens here is that Tier 4 is those clients are actually reviewed on a monthly basis to determine their progress towards goals. Tier 2 and 3, those clients are reviewed on an every other month basis. And so we also, again, look at the progress towards goals. There are times where Tier 4 clients go to a Tier 1 and then they move from a Tier 1 to a Tier 4. So it really just depends on what's going on in their lives. And we do have some clients that go from a Tier 1 to a Tier 4 because they've lost housing or they've, have a new medical diagnosis or something along those lines. So this tier review system really helps us review the case, be on top of what's going on, and revise and edit the care plan as we move forward to meet the family where they are. So we're never in a situation where we're saying to the family, oh, well, you didn't identify that in your intake assessment, we can't add that goal. So we're really always in the position where that care plan is a working document and we're monitoring it and adding as we need to based on what is going on with that family at that specific date and time. And so really, this tier system kind of helps us keep on track of what we need to do with the family and what they still need to accomplish. Sometimes these case reviews and these tier reviews are that we're saying, well, you know what, this family isn't participating at all. They're not actively engaged. We call them 4 or 5 times a week and they're not responding, and they might need to have a higher level of care. So there are times where, care coordination might just be too low of a level of care for them and they need more intensive in-home family support services. So those are some recommendations that we are able to make at this tier level opportunity as well. Okay, so I talked a little bit about this in previous slides. So just so that you're aware, before I get into the program data, some of the things that I've had questions about prior is related to funding sources for this program. We do have, like I said, county contracts for specific populations that are served in each county. So for example, in Allegheny County, we do support adults with substance use disorder, but we do not support those adults in Washington County. So all of these programs are currently funded by county programming that is, through either the Plan of Safe Care or it's different state initiatives where there's money associated for these specific activities. So some of the data, just to show you the powerful piece of the program and how powerful this program actually is. Some of the data that we've obtained is showed on this slide. And so for the clients that we have that have been referred from Children, Youth, and Family Services, after they're discharged from the program, we do a 30, 60, 90, and 180 day outreach to the family to determine if they're still on course, if they're still using the resources in the toolkit that we provided them during their enrollment in care coordination. When we looked at the data, 86% of families were not re-referred to CYF after their 90 days of closure with our program. 76% of those families were not re-referred to Children, Youth, and Families after the 180 days of closure with the TCI care coordination program. And then 84% of families also reported that they were using resources and community supports after discharge from our program, and that they were continuing to access those resources, and they did also report that they felt much more qualified and confident to support the needs of their children with medical complexity. 96% of families also reported that they were highly satisfied with the program after services, and these are just some of the statements that the parents had stated that care coordination at TCI saved my life and my family's. That was a 32-year-old client with substance use disorder. My care support coordinator is always available and never makes me feel stupid with any questions that I have about my son's care. And so that was a 28-year-old caregiver of a child with medical complexities. So a lot of this program is really focusing on just really meeting the family where they are and making sure that we're supporting and decreasing those barriers that the family has in all of those domains. So this is my contact information. I wanted to share that just in case you had questions, moving forward. I also wanted to thank the RCPA for inviting me to present today and about care coordination that we offer at the Children's Institute, and also thanking the counties for all of the program funding and things that they have made available to make these services possible. You can always feel free to contact me, but I wanted to just leave some time for questions in the event that there's questions about the program or other things that I can answer. So if we wanted to open the floor, I don't know if there's any questions that were in the actual question box, but we can definitely open the floor for questions now.
Great. So thanks so much, Dr. McTighe, for sharing that. It's been interesting to hear about your program and what you're doing. So if you have some questions, go ahead and type them into the Q&A section. I do have one to start us off, and I wondered if you can talk about what trends you're seeing with referral patterns, or even within the clients and the families that you're serving. Over the last 6 months, the world is very different than it was a year ago. What are you seeing with social isolation, increased home stressors, financial stressors? Can you share a little bit about sort of what you've noticed and how your services have changed in the last 2 months?
Yeah, that's a great question. So a lot of the things that we've noticed is increased, a couple things, an increase in the need for behavioral health services among caregivers. Caregivers that are actually requesting that they want to seek behavioral health care. We also have had increased stressors related to childcare. If there's specific nursing agencies that the family has that is coming into their home, they have more nursing agencies that are canceling on them, and then they're stuck without an emergency plan. So we've worked with those families to really create okay, here is what is going to happen when that occurs, and let's create an emergency plan that goes along with what to do when that nursing agency or that staff actually cancels on you at the last minute. The other thing that we've had a lot of increased needs for families is what to do with childcare, and also what to do with educational pieces. So I have to work, but I have these 3 kids at home that need to do all this stuff virtually for school, and what do I do in that situation? We've also seen some families getting behind on well visits and doctor's appointments, specifically because doctors aren't taking those they weren't taking those well visits unless it was a medical emergency. So we have had some families that have been referred for through Children, Youth, and Families for missed medical appointments, but it really is frustrating on their end because it really wasn't their fault. It was the nature of what was going on in the community. So there's a lot of stressors financially as well with employment. I think all of the barriers we have noticed being that there's all of the barriers being identified, all of the domains being identified as barriers rather than just one here and there. So that's a great question.
All right, another one for you. How do you wean services or care services with a family who really enjoys that level of support, who might be doing well, but they really like having someone in their corner?
Yeah. So that's
any strategies for that?
Yeah, that's actually something that's really difficult. So one of the things that we make sure that we do is we really explain the program from start to finish when they first enroll, because if they think that this is going to be a lifelong service, we don't want them to think that, because the whole idea is to empower the family to be able to take on the care by themselves. We do still have families that have been discharged and are doing fine, but they're still calling and they're still asking questions and things, and we take those questions as much as possible. We definitely do that. We do have families that have a little bit harder of a time to gain those resources and master those skills that they need. And we do have families that we call in that post-discharge, that 30, 90, 60-day discharge, that say, you know what, I need like a little jump start. Life got the best of me. I needed some more help. So we just re-enroll them and we help them with the supports that they need. It is difficult if they develop a really great rapport with the care support coordinator. But it's basically giving them also that self-esteem to feel like, hey, like we're their cheerleaders, to say, you did a great job scheduling that appointment. You don't need me. You did awesome, so things like that to make them feel much more comfortable.
That's really a win-win, right?
Yeah. Yeah. And also the other thing too that I wanted to mention is a lot of the resources that we are providing in setting up with the family, it's not just like we're saying, oh, hey, here's this resource, call it and see what happens. Like we're doing like a warm handoff so that they feel comfortable with these resources that are going to be much more involved in their life. Like say, for example, the food bank. We're giving that warm handoff of like, hey, this is the person that you want to contact at the food bank, so that they feel comfortable with that resource that we're providing, and we're kind of backing out because there's that warm handoff that goes along with it.
So it's a question about your team. So you certainly can't do this on your own, and you have a team of people. How do you match the right provider with the right needs? And, who do you have on your care management team? What kind of backgrounds?
Yeah, so we have a registered nurse that we have one registered nurse that deals with a lot of like the medical complexity piece, a lot of like the medical specialists, things like that. We all work very cohesively as a team. We have, so even if we also have 2 social workers and then myself. So, and that's in one specific county. And then, so we have like little pods in groups that are going to be moving, into different counties as we grow. But what's nice about our team is that when we have all of that different expertise, we have the ability to work. And that's one of the reasons why we have that tier review assessment or that case review, because that really helps us say like, hey, if the social worker is the lead on one of the cases, they might be saying during the tier or the case review, you know what, I'm really having trouble with this family in this specific area. And the registered nurse chimes in and says, oh, well, this is my experience with doing that, or let me take this over for you. And so it's really nice because we have all of these different varieties of backgrounds that support the family, even though they might not necessarily be the initial contact for that specific client. So we do, like I said, have a registered nurse. I have a background, my PhD is actually in special education. So I have a strong background in special education and in the school piece. And then we have the 2 social workers that are really familiar with community resources and things across the counties. So.
Awesome. All right, one last question for you. Do you have any data, or can you share about, how much money is saved across the continuum? If you have any comparative, or have you been interested in keeping that data? Because I think it's fascinating to see about how adding a service like this to, a family dynamic, how it could save money in the whole.
Yeah, so I'm actually in the process of collecting some of that data right now. We actually do have another very specialized care coordination program for a rare syndrome called Prader-Willi syndrome that we also support. And we have collected data of how healthcare the costs of healthcare has decreased due to this specific support. We're in the process of collecting some of that data now for this specific program for children with medical complexity. So that should be available like within the next couple months. Yeah, but we are seeing, even just asking families and some narrative data that we have, we ask families, how many emergency room visits did you have prior to enrolling in care coordination? And they go from like 12 to 2. you know, so it's there's a lot of data that we need to come through, but I'm anticipating that it's going to be a really positive outcome based on the services that are provided.
Awesome. It's certainly really interesting. I can see a follow-up to this presentation on that for sure, for sure. Well, Dr. McTighe, I want to thank you so much for your willingness to share your expertise and your program with us. We're nearing the end of our time. I want to remind everybody that the Connections Hall is open following this session. You can go ahead and say hello, play the games, look around in there, and then our next session is plenary session number 4, starting at 3:15, which will be Executive Deputy Secretary Clark Madden. For those of you who are looking for CE credits, those are available, and you'll need to find the forms on the RCPA conference website, not through the app. It's on the actual website. You need to have those submitted by October the 8th to Sarah Eister via email. So just a reminder to go ahead and do that. And then for anyone, whether you are looking for CEs or not, we really would appreciate it if you would complete the course evaluation. Let us know what you think. That is available via the mobile app only. If you go to the agenda and speaker section, you'll find it there. And we really appreciate your feedback. It helps us to communicate with our presenters as well as plan for future sessions. So we would really ask that you would take a few minutes to go ahead and do that. So Dr. McTighe, thanks again so much for your willingness to share, for an awesome presentation. And thanks everyone for being a part of Vision 2020. We hope you're enjoying the conference, and we'll look for you at the 3:15 plenary session. Thanks so much, everyone.
Thanks, everybody.